washing as the example. And then lastly, having opportunities. So it's not enough to have lots of knowledge, being super motivated, and then not have the opportunity, the resources, and the support to do it. If you ensure that people have the capabilities and the opportunities to do something, it increases people's motivation. And when you start doing something, you start doing the behavior, you increase your capabilities, learning by doing. You start seeing often the benefits of doing this particular thing, and you start increasing the opportunities to also do it. Because this is when we talk about demand side, but I'm talking demand side from the health providers. They start asking for soap. So that's where the opportunities would lie. And in applying this type of thinking, when it comes to implementation, in thinking, what do my staff needs? What do the health providers, what do the managers need to actually follow up, for instance? Do they have the capability, motivation, and opportunity to follow up and provide constructive feedback? It's an essential part of actually implementing monitoring and constructive feedback. And this relates a little bit to behaviors on different levels, because you have DMO maybe, an in-charge and a health worker, and again, to be self-critical and think, it's not only a matter of the frontline health worker who has to change. What are you going to do differently when this is happening? So I work a lot with health administration in Sweden, and they are busy saying, primary healthcare facilities, they should do A, B, C, D. Okay, what are you going to do? In 1 year from now, what are you doing to support that they actually manage to do what they should be doing? So that's something for us all on different levels and whoever we're representing to consider. What am I doing to ensure that that particular change has taken place in a year from now? So if a lot of the first behaviors around cleaning facilities and hand washing would be on the front line, it would be monitoring and providing feedback, compiling and reviewing data, for instance. So those would be things that also need to be coupled, that are rarely in the guidelines, because the clinical guidelines of the clinicians, but then there are all these other individuals who are also part of providing healthcare. Now, these are different types of implementation strategies. So we have education, printed educational materials, which could also include guidelines, educational outreach visits, having local opinion leaders, computerized reminder systems, and financial incentives. I'm going to call them up one by one. And important, useful, and effective implementation strategy. Do you think it is education? Please rise. Quite few, but a few hands up as well. Thank you so much. All right. Printed educational material. Yeah, a few hands. Thank you. Educational outreach. More. All right. Having local opinion leaders or informal leaders. Yeah. All right. Thank you so much. Computerized reminder systems. Yeah. Thank you. And then financial incentives. Well, I wouldn't say it's the clear winner, but close to. Okay, this is a little bit of an exercise, because I do believe, at least for the people that I've been discussing with here, training of trainers is quite a common strategy, that you cascade training, so education, right, which is really something that would target capabilities, for instance. And financial incentives, it will increase the motivation, right? And maybe having computerized reminder systems, it will sort of increase our opportunities to do things. Now, what the science tells us, my dear friends, is that they're on average, they're equally effective or ineffective, all these strategies. And when you look into the scientific literature on different implementation strategies, and this is really something that I think you should bear in mind, picked to also be tailored to the needs of the people who are supposed to change. So for instance, in a project in Nepal where I worked, we wanted to implement the different types of infection prevention and control measures, and my Nepalese colleagues said we have to train them on washing hands. We have to train the midwives on washing hands. That was the first strategy that I opted for, but I was quite certain that midwives in Nepal in 2020, they have been trained on how to chant many times. So if it's not happening already, then there must be another reason. So we asked them. So I sat down and we tried to start to really ask them, what is the root cause of this? And then they said, well, and this happens always, we have a lack of resources. That's the first thing. We can't do it. We don't have a sink, we don't have soap. But the more we discussed, it seemed that that could be fixed. And soap is not a very expensive commodity to buy. So, okay, so there was the thing of resources, which would be opportunity in the COM-B model. But then after a while, they said, well, we don't really think that this is such an important behavior. They don't think that washing hand is so important. And if you don't believe that hand washing is a very important strategy or a very important behavior to reduce infection prevention, for infection prevention, then it doesn't matter how many times you're going to be trained on how many seconds or what type of dance you should do while you wash hands, right? It doesn't matter if you have soap either. You need to really get people on board on the fact that why it is important. So really trying to dig a little bit deep. It's easy to say resources, it happens everywhere, it's global, but really also understanding what is it other than that. Picking in on what are the needs. So what you need to also consider then is to tailor strategies. So keep the end in mind. What are people doing differently in a year from now, first? Second, what do they need to do so? To really consider what are the needs among this group that are going to change. One thing we see also a lot is that people do a lot in the beginning of implementation. We cut ribbons, maybe there is a cake, people go for a training. There are things that happens in the beginning. Let's go. It's just that there is another project in a month from now. There will be another ribbon to cut, another training to attend. So we need to shift the balance, trying to mix the strategies which are supposed to support the initiation of change vis-à-vis the sustainability of change, which is implementation is all about. You have talked about monitoring as well, I have heard. So, of course, it's important to monitor things, to find out whether things are going as planned, and understand the results or the lack of results. But, and also in particular important, monitoring is the only way we could have for actually providing feedback. And when it comes to providing feedback, we know that it can really draw attention. So if you are implementing something and you start providing feedback, it has an effect on people. Because if I'm asked to provide essential emergency critical care, for instance, as a nurse, and I'm supposed to start doing and engaging in new behaviors, I also need to be revitalized by my manager saying, it was good when you gave fluid. It will give me much more sense of security in my tasks. Not doing anything is business as usual. Doing the new is what is quite frightening sometimes. So you need to be reassured that you're doing something right. And it's not enough always also to monitor maybe quarterly. If this is a behavior that I'm supposed to do on a daily basis or a monthly basis, it's not enough to get feedback in a half a year from now. So in the beginning of an implementation, I need to be reassured, and I need to feel as if this is something that my leadership is actually, they want to see this happening. They want to see that this is changing. So consider that in wanting to implement. I think that this is interesting. In Sweden, there have been studies looking into how much feedback is provided, and managers themselves are not always doing to the extent. Productive different teams, more than a different group, the least successful team, you're doing the right thing. It's increasing people's motivation, and it doesn't cost as much as financial incentives, which also could have other side effects. So, in essence, when you want to sort of try to do things differently, you want to unwrap this black box of implementation. In different positions, you want to really inform yourselves about the what, the who, the where, and informing and tailoring the strategies. So, if we're going to think beyond business as usual, I think clarifying what people are expected to do when implementation is complete, and also really to consider the different behaviors that we're expecting on multiple levels. To choose implementation strategies which are really informed by the needs of people. So we're not doing implementation as usual, but rather informed by the needs of the people that we want to adopt a new practice. And lastly, to monitor change and provide feedback with the aim of reducing uncertainty and stress amongst the people who are expected to change, to focus attention on specific tasks and also understanding how to further support implementation. Thank you.
Thank you so much, Anna, and thank you for getting everyone to stand up and sit down and wave and things. I think that's very helpful, and then giving a little bit of space to questions and answers at the end. And I would like to start with you, Dr. Jkcc, because you come from MUHAS. You are used to doing research, and you have been doing this for many, many years. And I'd be interested to hear from you, what do you think is different in engaging with implementation research from an academic perspective? Can you say something about your experience?
Thank you very much, Ulrika, for the question. Aligning these two words, academic and research, might already elicit an allergic reaction to some of us, particularly in the context of primary healthcare. So I will try to kind of get to the meat of what implementation research is from an academic perspective, but trying to align it to what happens in the primary healthcare facilities. So as the keynote speech has alluded, implementation research is different from regular research that we do, and I'm sure most of us do research as part of our daily activities, are either participants of research, some of us, it's our livelihood. But how does it differ? How does implementation research differ from regular research? Well, it differs in the sense that from the very beginning, the aim is not to generate new knowledge, but rather to find ways of applying the learnings to adjust how certain things are done. So that is the major difference between implementation research and other research that we might. Implementation is ongoing. So in a manner of speaking, you can think of implementation research as fixing a boda boda while the boda boda driver is fast riding that bike. So it is making minor adjustments, but these adjustments need to be informed, of course, by the needs and the situation on the ground. Which brings me to some few key points as to how implementation research differs from regular research. The very first thing is that implementation research is problem-oriented. As the keynote speech also alluded, when you're thinking about implementing something, you're always thinking about the endpoint. At the end of the day, what do I expect these people or my healthcare workers, what do I expect them to be doing? So in implementation research, you really are starting with the problem in mind, but not only just the problem itself, of course, it has to be very practically oriented. What are they doing differently? Who is doing it? What do they think about what they're doing? Who is supporting what they're doing? So it's really context specific, which again I can link to some of the discussions which were provided yesterday. We had one of the presenters showing this very interesting costing graph and revealing that there are certain districts with the same amount of expenditure but with vastly different outcome findings. So of course there might be many different reasons as to why you'd spend the same amount of funding or the same amount of money but having vastly different outcomes. There could be many different reasons, but perhaps some of those reasons could be what are people in health facility X doing differently from health facility Y, because it is the same guidelines, it is the same policies, it is the same procedures. But really at the heart of implementation research is stakeholder engagement. In order to have effective and useful and practical solutions that are tailored to a specific context, you really need to engage those people who are responsible for the implementation. We can't come up and say, all right, we will train you how to wash hands, if the problem really is there are no sinks. So you really need to engage the stakeholders, and this is based from my experience, from the very beginning. Before you have even concretized what the problem is, you need to have a sit down with people who are actually working in that specific context and tell them to tell you what they think about this particular issue, what are the key issues that they think are enablers, facilitators, and maybe what do they need to implement it. Understanding of that context from the very beginning will ensure that you are actually working on a problem that at the end of the day is more likely to be uptaken once a solution is provided, because you're actually targeting a need that has been identified from the actual stakeholders themselves. But to wrap this up, the whole aim of implementation research is, at the end of that implementation research, you come out with some concrete suggestions and recommendations that can be very readily implemented within that context to improve how certain things are being done. Thank you very much.
Thank you so much, Dr. Kasusu. Moving over to Dr. Kendia from PIRA. PIRA has a keen interest in research, and especially in implementation research. So I'm interested to know why is PIRA interested in implementation research, and how do you think these concepts and the application of these concepts that Anna have been talking about this morning can be integrated into our routine systems and processes, and what do you think are some of the entry points for starting to apply this knowledge into primary healthcare?
Thank you very much, Ulrika, for that question. Indeed, as PIRA, our major interest is here to have the quality services. Quality is very, very important. And because of that, the knowledge of implementation research and research at large is very, very important, as pointed out also by the WHO report of 2013, that has put it very clear that if we want to achieve universal health coverage, the issue of research, the frontline workers, is very, very important. They need to come up with some targeted solutions, customized to their level, so that we can come up with a solution that can produce fruitful results. So, implementation research is coming on board here now to bridge the no-do gap. That is very, very important. And because of that, for us as PIRA, our interest is to implement some of the interventions, and then sometimes we need to customize depending on the contextual issues. But of more important is to come up with an appropriate strategy that can give the desired results. And because of that, now the role of implementation research becomes very, very important. So for us, we need it, and when it comes to discussing about the entry point now, we need to understand the situation, the current situation, the landscape in terms of conducting implementation research or using implementation science at large. Doing the SWOT analysis is important, and then the needs assessment to understand our capability gaps, and thereafter we can embark into having a very clear roadmap in terms of how we want really to improve the capacity in terms of doing the research. And not only doing the research in a sliding way, we need also to define who are going to do the research and who are going to just impart knowledge in terms of implementation science. So the lower level, the subnational levels, probably they might need more of implementation science knowledge, but we need to define other cadres that are now going to be imparted knowledge in terms of really conducting the implementation research. But the good news is with the current investment, we also see even the medical officers at the level of the health centers, so that is an opportunity for investment in terms of the knowledge for the implementation research. Just to expand a bit in terms of the roadmap, we need to have a very clear visions where we want to go, the mission and concrete strategic objectives. And some of the area of interest within the strategic objective is capability strengthening in terms of capacity in conducting the research itself and the knowledge of implementation science. And of course, we need some infrastructure that can support people to be able to conduct the research. The issue of networking with the universities like MUAS and others, SUSA and the others, is very, very important so that we can be able now to come up with the partners in imparting knowledge and also conducting some of the research work with also some of the institutions that are research institutions in countries. The other interesting then, we need now to have a way that we can generate those informations, having a repository that we can put all the information together. Then we do the knowledge synthesis, and then we form the strategy that are going to be implementable in our context so that we can have a very clear and fruitful results. That is what maybe I can say for now. Thank you, Ulrika.
Thank you so much, Dr. Kengia, and that leads us nicely over to Chipole, because you have attended some capacity building in implementation research that was actually led by our keynote speaker, Anna. And I'm interested to know, how did you feel it relate to your everyday practice, and how do you see that you can apply these concepts? And I think Dr. Kengia pointed it out well, that it's both about the science about we know about implementation that we can actually use to improve our practice on all levels of the system, but also in terms of thinking about when we do research that we study the things that really help us to bridge the know-do gap. So can you tell us a little bit about that experience? Over to you.
Thank you, Ulrika. Like we've heard from the keynote speech and of course the presentation, for over 3 decades we have not been able to bridge the gap between research and practice. And of course from the training and the capacity building, we were able to notice how increasingly implementation research has sort of been something of interest to implementers. So last year, December, we had a training, of course supported by UNICEF, for the national team, both from Ministry of Health and PILI, where Professor Anna took us through implementation research, the concepts, the models, and we also had practical sessions. So having said that, we realized how capacity building is important, because among the challenges that the health sector has been facing about bridging the gap is that is the difference in context and of course the peculiarities in terms of the context, the environment. As we know from the number of regions we have different environments. So if you are to implement implementation research in
maybe the regions up-country in Katavi, Rukwa, the Southern Highlands, it's different from someone else implementing the same concept in the Eastern Zone. So the difference in context and the peculiarities require you to come up with different resources, maybe probably use different methods and different tools. And of course, all of that will also pose different challenges. So we had a very successful workshop on that, where all of us were able to come up with individual projects from different areas, from different service areas of interest. We had projects on quality improvement, where the issues of behavior came out very clearly. Of course, you cannot separate behavioral issues from the issue of quality. So we had a lot of time to look into the models. The COMBI was mentioned here. So we looked into the capacities at different levels, the national level, the regional level, the council level, and the community level. What are the capacities in these different contexts? What are the resources? What does it take for people to do what they're supposed to do? Of course, from the systems perspective, from the structural perspective, and from the services perspective at the practitioner level. So we also had, a range of topics, like I said, from different service areas, from systems, from policy people. We had people from the Human Resource Development section who looked into how implementation research can be incorporated into training curricula for our health professionals. But from the implementation side, from PILI, we had a range of other topics addressing all the health systems block. We had a very interesting topic from the health commodities people, the antimicrobial resistance. So that was a very interesting, we all had interesting projects from all different areas of the blocks. And of course, at the end, we came up with a roadmap that is still work on progress. Like Dr. Kengia said, the roadmap actually is there to lead us on what are the methods, on the vision, the mission, of course, but what are the methods or the methodologies that are going to be employed in order for the health sector to incorporate implementation research into our daily work. But then again, all the strategies are within the roadmap. It is still work on progress, but we hope when the roadmap is ready, capacity building being one of the strategies for incorporating implementation research, will be able to successfully make significant steps. Thank you.
Thank you so much, Chipole. And I think it's clear that we are discussing three interrelated things here. We are talking about the science of implementation that Anna introduced to us. What is it that really, what do we know about implementation? And this is really something that's exploded over the past decade, because we didn't used to really think about it. We thought it was enough to write a guideline, we send things out, and it's done. So it's a science of implementation. It's the application of that science to our practice, and it's the application of that science when we do research to improve our practice. So these are all interrelated. We have some few minutes, I believe around 7 minutes for Q&A, which is very short. So I would like to welcome a few, try and keep your questions brief, and please reach out if you are interested to discuss more. We have the UNICEF booth here at the conference. We have a lot of materials there on implementation research and projects that we've done with the government and MUHAS especially, and also come and take our contact so we can continue the conversations. But if there would be a few questions in the time we have left, I see one here at the front. Is there anyone who can bring a microphone? Yes, microphone coming. Karibu sana.
Asante. Thank you very much for the very nice presentation. I have one or two questions. Implementation research is also called operational research. Implementation research is also called operational research, application research, intervention research, or action research. It has to do with the needs of the people, and actually you have to take into account that you have to give feedback and so forth. The role of stakeholders is very important, as Dr. Kasusu has said. So stakeholders' engagement has to be comprehensive. It has to be continuous, and it has to be cross-section, horizontal and vertical. Horizontal across peers and vertical across levels. How do we engage stakeholders? For example, we are stakeholders here today, but how do we engage stakeholders for policy action or policy change? That is my question.
Thank you very much. I think we can take, if there is another question, and then we'll answer them both at the same time. Anyone else?
I see there's a hand here, madam.
Yes, please.
Here.
I think over there. One more.
Let's start here, I think.
Is the microphone
Ma'am.
going there?
This way.
Oh, it's here. Okay, sorry, it's hard to see. Yes, karibu. And please welcome to the booth. Yes. Okay, karibu.
Thank you very much for the nice presentation. I'm Dr. Sadok from the Office of RMO Geita Region. My concern is, first of all, how is the preparedness for financing this implementation research? We are currently facing some of the challenges, and among them is integrating the component of research as the 7th building block as per WHO. And we need to know the priorities as per health service delivery. We have so many projects, and we are not sure if they're going to be financed. And currently want to know the level that this implementation research is operating at national level, regional, or at the point of primary health care facilities. Thank you very much.
Wow. Thank you so much. I think we can only take 2 questions. I'm sorry about that, because we are asked to wrap up. I'd like the first question, Kasusu, could you say something briefly on stakeholder engagement? It's a big question. How do we engage stakeholders for policy change? So it might be a bit outside the scope of this, but please share something about how you've engaged with the stakeholders during the process.
Yeah, thank you very much, Ulrika, and thank you for that wonderful but huge question. How do we engage policymakers, particularly when the implementation strategy involves a change of policy? I can draw from our experience at MUHAS while we did our very first round of implementation research, and this was in the area of community-based health programs, looking at mentorship and supportive supervisions. After we had collated this evidence, we held our very first symposium on implementation research. And during this symposium, we reached out specifically to PORAL, Ministry of Health, and other relevant stakeholders, first of all, to receive or to disseminate our findings, but then we also had a breakout session to now engage them at that point in time about what do they see, what is the relevance of implementation research, and how can it be sustained in order to ensure that we are continuously making adjustments into how we are implementing certain activities for improvement of quality of care. So that is one approach, but I'm sure there are many other approaches that can be utilized to engage implementers, depending on the context, of course, and the breadth of the policy that needs to be modified or altered. That would be my reflection.
Let's continue that discussion. It's a big one and a good one. And then we had a really great question, and I think this is really getting to some of the core of the matter around, really, are we going to do implementation research on top of everything else we're doing? And Dr. Kengia, would you like to say something about that from the side of PIRAL?
Thank you very much. The first thing that I want to put it out clearly in terms of research, conducting research, in 2019, we decided clearly that we need to put the agenda of data use and operational research as one of the very important functions within RHMT and CHMTs. So initially we had 10 functions, but we decided to put additional functions as 11 functions to enhance data use and operational research. For RHMTs and CHMT, it goes down there. So this is an opportunity also for planning and budgeting to ensure that we incorporate some of the budget for conducting research. But talking about how the level of the conducting the research itself, we have published a paper just recently in terms of the capacity in conducting research in Tanzania public health systems. It's very clear that the capacity is low, and what we are really intending through the roadmap that I have talked about is one of the very important strategic objectives to come up with how can we impart knowledge of implementation research to our individual, to all peoples in our health settings. So one of those areas, of course, the capacity building, so that we can uplift the level of conducting the research. And the other things is to ensure that we have the supportive infrastructures, and of course, not only the supportive infrastructures, but also to tap all those informations in terms of having repositories, where all of us are able now to access some of the publication works that are conducted at the primary care levels. Thank you very much.
Thank you very much, Dr. Kengia. And with that, we are going to wrap up this morning's session. Thank you so much for everyone's engagement. We hope we've awakened some interest in many of you in this science and how we can use it to improve our practice, to bridge the no-do gap, and how can we integrate it into our routine work without overburdening it so that we can engage implementers at all levels. So have a nice day, and thank you very much. Over to the chair. Thank you.
Thank you very much. Let's give them a warm round of applause. If you can, please stand in front of the tables for a group picture. I'll have one gentleman stand on one end and the other on the other hand. In front of the table, please. Thank you very much. Team taking the picture, let's have this very good picture. I would, as they take a picture, I'll proceed with the announcements so we move fast. I would like to recognize the presence of colleagues from the Ministry of Education, Science and Technology with us. Thank you very much. Now, all the presentations, all those who are doing the presentation, I would kindly ask you to make sure, Nikas Lewis, if you can wave all the way at the back, please look at the back and see Nikas Lewis. Those of us doing presentation, make sure he has copies of your presentation. We are going to present them to participants. We're now moving on to the parallel session. And please listen carefully to these sessions, because they may not necessarily be on your program. In here, we have the session by the Ministry of Health that is going to look onto the control and elimination of neglected tropical diseases for achieving universal health coverage in Tanzania, progress towards reaching the last mile. That discussion will take place in here. At Kawawa Hall, by EGPAF, they're going to discuss use of regional accelerated strategy in primary health and accelerate efforts towards sustainability of health programs in Tanzania. This is happening at Kawawa, and it will be led by EGPAF. At Zanzibar Hall, building resilience, primary healthcare strategies for climate and emergency preparedness. JPIEGO will lead that at Zanzibar Hall. Now we have Rubondo Hall that is going to have abstract presentations on healthcare, financing, and then we have the Secretariat Hall that is going to discuss data use, innovation, and research. This is happening as soon as we step out of this room. Now, the rest of the floor are onto the program. This will go all the way up to 11 o'clock, where we shall go for tea break. Now, I believe we all have this program booklet, so I will only read 2 sessions that are not written on the program. After tea, Rubondo Hall will be discussing leadership and governance, whereas the Secretariat Hall will be discussing community engagement, science and delivery, service delivery. Rubondo, leadership and governance, whereby Secretariat will be abstract presentations on community engagement and service delivery. After lunch, 1 to 2 p.m., then from 2 p.m., Rubondo Hall will be discussing communicable diseases, whereby Secretariat will be discussing reproductive, maternal, newborn, adolescents, and child health. Tomorrow, we shall reconvene here in the morning at 8 o'clock and start with the presentation in the hall. And being
It was fantastic. Although I came in late. Yes.
Ah, okay. It's coming, it's coming.
Yeah.
1 minute.
So I would like quickly to invite to the stage Dr. Yahya, Mr. Douglas, Dr. Akili, and Mr. Muhiche. They can see. Who from there? Unaona tu LinkedIn. Karibuni. Karibuni.
Ushers, please assist the participants into their respective rooms. What we have right now is the Ministry of Health taking us through control and elimination of neglected tropical diseases for achieving universal health coverage in Tanzania. Progress towards reaching the last mile. And the session is already starting and is going to be moderated by Dr. Ntuli. Dr. Karibu, we are good to start. Those of us leaving the room, if we can do it quietly, so that we can continue with the session in the room. Thank you.
The ushers are already outside. You'll just...
This is Akwetu?
Yes, Akwetu.
Numbers are it. So, ladies and gentlemen, let me take this opportunity to invite you to this very exciting fora where we get to discuss issues around the neglected tropical diseases. And our main theme for this, so guys, can we stop having some sessions? We have to start. So, our agenda to this forum is control and elimination of neglected tropical diseases for achieving universal health coverage in Tanzania, the progress towards reaching the last mile. Let me take this opportunity to welcome you all to this very, very exciting panel, and thank you very much for making time to this forum, which is dedicated to neglected tropical diseases. 2 weeks ago, I was attending one of the very big conferences in Salzburg, and one of the issues which emerged in that conference, it was, why are we calling it neglected tropical diseases? And people are feeling like these diseases at some point might turn out to be pandemics. So the word neglected should be carefully taken, because you never know when this disease might turn to be the pandemics. So I'm very much excited today to be joined by 5 distinguished panelists. And without further ado, I would like to actually invite the first presenter who is going to making a presentation on the issue with regard to the overview on the control of NTD in Tanzania. And our first presenter is Dr. Clara Jones Mwansasu. She's a parasitologist, entomologist, and a researcher with a PhD, currently serving as a program manager for NTD at the Ministry of Health, Tanzania. With expertise in coordinating and implementing NTD control and elimination activities. She oversees interventions and operational surveys to strengthen NTD surveillance. She's also serving as a co-chair at the WHO initiated Global Oncoscarsis Network for Elimination, GON, whose mission is to empower endemic countries reach the 2030 NTD roadmaps oncoscarsis targets. Previously, she taught parasitology and medical entomology at the University of Dodoma. So please join me in welcoming Clara Jones to take us through in her presentation. Dr. Clara, karibu sana. So I'll be very strict with time because I would love in the end to have adequate time for us to discuss. Clara, time is yours.
Thank you. Good morning, everyone. I'm not going to repeat my introduction. I'm just going to go direct where I'm going to take you through the control of neglected tropical diseases overview in Tanzania. First of all, what are these neglected tropical diseases? This is a group of diseases. As per WHO, they are grouped in 20, and these are caused by fungi, parasites, bacteria, toxin, as well as virus. So if you see at the presentation there, we have diseases like scabies, which are caused by ectoparasites, but we have Chaga diseases, leishmania, as well as human African trypanosomiasis caused by protozoa, as well as those which are caused by virus, bacteria, fungi, and as well as venoms, which is very new in our world. And also we have helminths, which example is Echinococcus, Jancuculus, lymphatic filariasis, soil-transmitted helminths, schistosomiasis, as well as onchocerciasis. So these diseases are called neglected tropical diseases because they are found geographically in the tropical areas. And Tanzania, being part of these tropical countries, is not excluded from being endemic to these diseases. So in Tanzania now, we have these diseases, and as per WHO categorization, these diseases have been grouped into different groups depending on the depending on the intervention which is in place. So we have those diseases which are targeted for preventive chemotherapy interventions, and we also have diseases which are the intervention focus most on case management. For those which are targeted for preventive chemotherapy in Tanzania, we have 5 diseases, and this is which we are dealing with as the program. And this is onchocerciasis, lymphatic filariasis, trachoma, schistosomiasis, as well as soil-transmitted helminths. The other diseases which are also endemic, these are entities which are also endemic in the countries, for now, they are being dealt with other programs within the ministry. So the neglected tropical disease control program is under the Ministry of Health in the Department of Preventive Services, and this is how we operate. This is the implementation structure where we have the central level, region, council, as well as community level. So at the central level, we operate together with the PILI, and our role at the national level is to do advocacy. We conduct training. We also conduct resource mobilization as well as M&A. This implementation is really is going well because of the collaboration we have with PILI. And now going down, cascading down to the regional level at the regional secretariat, the role now goes more to the PILI, where at the regional level, they conduct advocacy, training and supportive supervision, supporting the CHMTs as well as M&E. And then down to the council level, the role at the council is social mobilization, training of frontline health workers, distribution of medicine, which were mobilized at the national level, as well as M&E. Now at the community, the role at the community is social mobilization, training of the CDDs, and I think we are going now to get benefit of the currently CHW CHW intervention, which is being implemented as one of the priorities by the ministry. And also at the community, the community do drug distribution, data collection, as well as reporting. Now, so the implementation really is done at the community level. Once the implementation has been done, then the arrow now changes where reporting from the community goes to the council, then to the region, and to the central level. So now, implementation of all these interventions are guided by the HSSP 5, 2020, which is 2020-2026, and also we have the neglected strategic master plan of 2021-2026, the NTD sustainability plan of 2021-2026, as well as the WHO NTD roadmap. What is our goal as the program or as the Ministry of Health? Our program is to accelerate the reduction of the 5 PCT, the preventive chemotherapy NTDs burden, and sustain the gains of integrated NTD elimination measures in all endemic council in Tanzania through a multi-sectoral approach. So now we have this intervention which we are implementing as the program. Some are core to the program, and some we do implement them through the cross-cutting approach. The program strategic intervention include mass drug administration, where with these 5 diseases we do, depending on the nature of the disease, we do MDA. Which with lymphatic filariasis, we usually do MDA using ivermectin and albendazole at community level, targeting individuals from the age of 5 or individuals in the risk area from the age of 5. And also, we do morbidity management and disability prevention. This includes those who have been affected by trachoma, as well as lymphedema and hydrocele. We have diseases like schistosomiasis, which we have those people affected, but at the program level, we have not yet started an intervention to address the morbidity challenges with diseases like schistosomiasis. And also, we do advocacy and sensitization on behavioral change toward control of NTDs, health system strengthening to ensure that there is sustainability even after the donors have left. And also, we conduct monitoring and evaluation, which some of the presenters later will talk more about how we do these researches and the role of the researchers as we eliminate these NTDs. So if now going to those interventions which we do with other departments or in a multi-sectoral approach, there is collaboration with WASH section through NTD WASH Forum, where previously we would have challenges with trachoma, where most of the areas where we had persistence of trachoma were all those areas without water. So we are now collaborating with the WASH section from the preventive services to ensure that all those areas which are endemic and have persistence with trachoma infection get water supply. But also we do the collaboration with vector units as reflected in the National Integrated Vector Control Guideline of 2022. So now I'm just going to talk you through the snapshot of each disease which we are addressing at the program level. Starting with lymphatic filariasis, I would say on my left side, because I don't know if my left is also your left side as well. So on my left side is the prevalence at baseline, where before the intervention, a baseline was conducted from between 1998 and 2004, and all council on that basic basic mapping were found to be endemic to this lymphatic filariasis. But again, this basic mapping which was done was another remapping was conducted just to confirm the findings which showed that the whole of Tanzania was endemic to LF. So after the remapping which was conducted in 2014, between 2014 and 2015, lake zones and northeast regions, Kilimanjaro and Arusha, were excluded, were found did not reach the criteria for endemicity, and so we remained with 119 councils which were endemic to LF. And so in all those endemic districts which were 119, MDA for LF started first in 2000 in Mafia district, and later on expanded to cover all the districts which were 199. And at that particular moment, the population at risk was estimated to be more than 31 million. So now in the course of implementation, we usually do assessment surveys to ensure and to see the effectiveness of the intervention. And so in all these 119 districts, MDA was conducted using albendazole and ivermectin, and was provided to the population, at-risk population, from age of 5, and everyone who is eligible got their medication. So as of 2024, we have achieved a lot. So on my right side, you see the current map of the status of active transmission of lymphatic filariasis in the country, where 7 councils are still on MDA. From 119, we have shrunk the map to remaining with only 7 councils. And from the at-risk population at baseline, which was 31 million, now we have only 102 million people from these 7 councils which are at risk. So this is really a big achievement, and we thank the government for providing the environment for us to be able to do this intervention. So when we talk about trachoma, again, in trachoma, the baseline was conducted from 1999, and this included the safe strategy. During that period, safe strategy was implemented in focal areas where they are most likely to be infection. Then the safe strategy was implemented. And this, in 2006, expanded to cover 43 districts with trachoma follicular of more than 10%. So by 2014 and 2015, the baseline mapping now was completed in all of the country, and 71 districts were found to be endemic with active trachoma at risk, and were under MDA in all these 71%. And with trachoma, we provide zithromycin from the age of 6 and above in all endemic region. And so this was in 2015, and going forward now, by February 2024, we have scaled down the number of districts requiring MDA from 71 to 9 districts, and the disease burden is high among pastoralist community living in north, central, and southern sides of country. Now, the population has dropped from the 12 million at baseline, and now we have 2 million from those 7 districts. So this is again the snapshot of the baseline for trachoma, where during the baseline on the upper map shows the TF status, which is an indication for active transmission, where we had, at baseline, we had 71 districts, as I mentioned, and out of these 71 districts, 62 has attained elimination through the MDA intervention, where we provide zithromycin, and we have 9 left, Of these, 7 still need MDA, and 2 are waiting transmission assessment surveys. Now, the third disease is onchocerciasis, where I've been informed that I have 2 minutes left, so I'm going to speed up my talk. So we have onchocerciasis, which at the baseline, it was endemic in 28 districts, and actually onchocerciasis is mainly found in the highlands, and so during the baseline, the prevalence was real high, which ranged between 45 to 95%. And we have been doing the impact assessment survey all along during the implementation, where the first implementation started in 1994. And as of 2024, we have 30 districts. We have 2 more districts added to the endemic districts which were left behind. But the major achievement in onchocerciasis is that we have been able to reduce the burden of the disease. The prevalence in these endemic districts have been lowered from 45 to 90, and now we are talking of the prevalence between 0 to 6. And so we are still striving to ensure that we reach the elimination goal. And so the fourth disease is soil transmitted helminths, where again, at baseline, it was endemic in all of Tanzania. And and in this soil transmitted helminths, the targeted group is children of school age children between the age of 5 and 14, where we provide albendazole during school mass drug administration. So as of 2024 now, we have been able to lower the burden of the disease. However, we have not yet completed doing the impact assessments due to shortage of funds. So of the 184 councils, we've been able to conduct impact assessment in only 82 councils, and of which 5 councils reported more than 50% of the prevalence. And the achievement in this area is that 9 councils are now non-endemic, and we plan to continue MDA as well as complete the impact assessment surveys in the remaining 102 councils. And lastly, I'll talk about, in these diseases, I'll talk about schistosomiasis, where again, previously the basic mapping indicated that schistosomiasis was endemic in all 184 councils. And again, the at high risk group in this one is children, again, of the school age children between the age of 5 and 14. So we also usually do mass drug administration using praziquantel in schools. And so all of the districts in Tanzania were subjected to MDA for praziquantel targeting those children. And biggest achievement is that we have attained 100% MDA geographical coverage, meaning that each geographical area, each district where MDA is needed, we've been able to conduct those MDAs. And now, in the impact assessment now, with the cause of these assessment surveys which we conduct, it was recommended that we should not continue doing a blanket treatment because schistosomiasis is a focal disease. So now we are not doing at the district level, but rather we have shifted to conducting MDA, but focusing mostly at the ward level. We are doing it at the sub-district level. Now, what are the challenges and mitigation strategies facing the program? First of all, we have a challenge with an optimal coverage during MDA. And this mostly, we have this non-systematic compliance. People just don't want to take medication because they feel that they are not at risk. But now, what do we do as a program? First, we modify the strategies where in areas we do enhanced supervision coverage. We do implementation research to find out, mostly in some areas we do qualitative researches, just to find out what exactly is making people not to comply to this intervention. And also we are implementing gender equality and social inclusion intervention. Another challenge is inadequate MMDP services. We have not really completed the mapping, so we are continuing to ensure that we have mapped all those who require intervention, as well as strengthen the resource mobilization. And then, because the program is mostly donor dependent.
Can you wind up? Can you wind up, please?
Okay, thank you. We have the issues with support, the sustainability after donor funding, as well as persistence and recruitance of NTDCP. So as I wind up now, there is this big achievement we have achieved as the program and also as the world in the fight against NTDs. As you can see, the country commitment to ending NTD is that never before has NTD received high-level political attention in the country, where in 2022, we witnessed Her Excellency Samia Hassan's 2030. So this was really a very big step because our president was among the 4 world leaders to champion the effort toward ending NTDs. And furthermore, the president committed to supporting the NTD program, to support the program, NTD, not only in Tanzania, but beyond the borders, where she pledged $300 million in the last mile. And so now, as the country and as a program, we are very proud, and we're looking forward to reaching the 2030 NTD roadmap targets. Thank you.
Thank you. A round of applause to Dr. Kirara. Thank you very much for taking us through the overview of control of NTD in Tanzania. Now, Research Officer at the National Institute of Medical Research, with boast experience of 23 years working on the NTD.
Yeah, good morning. We'll start where the first presenter has ended, about challenges that provision of mobility management for prevention of disability due to NTDs is an issue at the Ministry of Health. So we would like to share you where are we now. I will present first part and my colleague Mbakisi will follow. We are following the roadmap by WHO 2021-2030, where there are a number of issues. One of it is about countries has to provide guidelines for managing NTD-related morbidities, therefore preventing further disability for patients in the populations. I would go for morbidity due to lymphatic filariasis. As the first presenter said, is that lymphatic filariasis is being closer to elimination of that map of shrinkage, but that is in respect to transmitting attention. We are trying to make sure that we follow what WHO is advocating, that we have, first of all, each have 100 geographical coverage for the availability of minimum package of care, as well as to have some selected health facilities that are actually actively engaged. Their strategy, it was an issue. Do we know where the patients are exactly? Does the health provider know how to provide the care to the people with the morbidities due to NTDs? We know these are even neglected during our programs in the teaching institution. So they have rudiment of knowledge on the NTDs. So when it comes to management, it could be a question. Patients also know the minimum package, because those who have condition, they have to care themselves. We have to train or to provide education. Are they supported as well? They need the social support as well as economic support. With regard to morbidity due to lymphatic filariasis, there are 2 morbidities, hydrocele as well as lymphedema. So in all cases, I will take through the steps. First of all, we have to identify them. where they are. Then we have to make sure that if it's hydrosil, they are operated at 80%, and we have to capacitate the health facilities in the district council, which we call evaluation unit. We have to train frontliners to manage conditions. Also, we have to provide health education to the patients. We need to integrate the services into the health system because we cannot do it vertically. We have to have it done at the health facility, not like now where NGOs, partners are implementing at rudiment levels. We have to establish clinics, like what we are doing with the major diseases, and then we have to continue with testing. In our case, as program, as Minister of Health, we have tried to estimate the burden and prioritize this as in terms of high, medium, and low, as based on the prevalence of the conditions in the country. If you can recall the map by the past presenter on the infection before the intervention and after the intervention, you will see that the 7 district councils that have still prevalent infections are located in the coast belt of the Indian Ocean. And you can see as well the morbidity is concentrated at the coast belt. Why? Because before intervention, the endemicity of the disease was high at the coast belt, as geography also determined the transmission. You know, this is a vector, is a disease transmitted by vector mosquitoes, and you know malaria as well is in the same area. So about 32,000 hydrosil cases, 12,000 especially for hydrosil. So far, 11,000 have been operated. Those have been operated through organized camps that are done by specialized surgeons and level hospital. So the surgeries started in 2008. Tanzania is one of the countries that is implementing this morbidity management compared to other countries. We are not behind. It's only we have strategized, and we put more emphasis on cutting the transmission, and now we have to embark to alleviate the conditions. You can see the increasing level of surgeries, and we thank the financial support from different organs as stated, Crowns, End Fund, CNTD, Statoil, Equinox, and the like, that supported the major funding that is coming from the ministry. On lymphedema management, as I've said, that we have to train frontline health workers, but we have to incorporate the provision of service within the health system so that the primary health care clinics at the bottom there are able to identify as well to manage the conditions. The minimum package of care my right-hand side of the table, normally we will manage conditions with the chemotherapy, with the pharmaceutical preventive drugs, but that is at the health facility. But it comes to the patient, you have to manage it by providing education to the patient, which is a minimum care, hygiene, exercise, elevation, wearing shoes. That helps for those who have the condition. But what is the plan of integrating into healthcare system? We are planning, and we work with the PILI and the Minister of Health and the other partner institutions to start the reference hospital as first regional hospital clinic for morbidity management as far as lymphatic filariasis is concerned. We are targeting to work with the Lindi Hospital and then Tanga and one in Pwani. I have said about this. May I now say that we intend to use community health workers as pivot when tracking cases. This is a base at the community who reside there and live with the patient. We need to digitalize the reporting so that we have timely we receive, managers at high level receive cases and plan for intervention. And then establish clinics. You're welcome to complete the section. Thank you.
Thank you very much. So this is the second part of the same presentation, and we're going to talk about the MMDP part of the trachoma disease, which is a bacterial, as the first presenter has introduced it. So for the country to be validated as eliminated trachoma, there are two criteria. The first one, that the active infection should be less than 5%, and then you should be able to make sure that people who have got affected by TT, like trichosis, trachomatis, which are unknown to the health system, should be less than 0.2%. So in order to bring down that level in areas where the prevalence of TT is very high, we do the MMDP, which is a minor correction of the eyes. We call the TT surgeries, which is the first part of the safe strategy, which was recommended by the World Health Organization. So basically, thematically, in order to identify the burden of the disease in the community, we need to conduct active case finding house by house to identify through a trained case finder to identify how many numbers of patients are there in the village. And then once the trained case finder identifies or suspects the number of TT cases in the community, is now we go to the next step, which is now like confirming the number of cases which have been identified by the case finder. This is called screening. This is done by the trained personnel, who could be the ophthalmic nurse or a person who has got special training on eye care. So once he confirmed or she confirmed the number of cases in the community, now we do counseling, because people need to understand why they need to take surgeries of the eyes, like the minor correction of the TT. And then once they accept going for the surgery, we organize for the TT camps near the community, and then we mobilize the TT surgery team. And then after that, we do surgeries, and then we do post-surgeries follow-up. We do day one follow-up for to remove the bandage, and then we do day 7 follow-up to remove the suture, and then we do 3 to 6 months follow-up to make sure that there is good progress, and if there is any complication following surgery, then appropriate measure can be taken to make sure that this person is safe from being blind. So this is how normal, these photos indicate different stages of how we do in managing the TT surgeries in the community. As the first presenter identified, so we have actually reduced the burden by 52%, which is over 50%. Over 45 districts has qualified to eliminate trachoma in this category of TT, and we are left with 39 districts, of which we hope, as the first presenter said, probably by 2030 we'll be able to attain such goal. So in order, we know we can, as a program, we cannot do it through vertical programs throughout. We need to integrate this through our healthcare system. So in every district that we are assured that now we have brought down the prevalence of TT to below 0.2%. So actually what we do, we capacitate the district to do it. Actually, basically all the surgeries that are being done in the community are done by the health workers who belong to such particular district and such particular healthcare facility. So once we are done with the surgeries, we leave behind all the facilities, all the equipment, and plus the capacity that we have brought to them, and then we do the transitioning training to make sure that now the district medical officer can be able to plan to manage the occurring cases after we have managed to bring down to below 0.2%. So basically that is what is being done in the TT surgery as part of the MMDP intervention for trachoma, and I really appreciate and thank you very much.
Thank you very much. A round of applause to Ambakisia, please. That was quite some marathon. Thank you very much indeed for saving time. So ladies and gentlemen, now I proceed to invite over Dr. Yaya Derua, who is a senior researcher at the National Institute of Medical Research with a PhD in mosquito larval ecology. He has an extensive experience in researching mosquito-borne diseases, in particular malaria and lymphatic filariasis. His contribution includes studying mosquito ecology, behavior, and mosquito control interventions. Dr. Haya, the floor is yours.
Sorry. Good morning. Is about the role of medical research in a to NTD control program. This part of the research is very important. And then we are looking at the institutions in Tanzania which conduct NTD research. We have research institutions, we have higher learning institutions, and we have partners who also conduct research on NTDs. The research areas in NTDs are many, and I can say Tanzania is rich in research in NTDs. We have research on epidemiology, which actually do define the parameters of the disease. We have research on mapping, and nowadays we have advanced technology for mapping landscapes, which produce good map and allow targeting interventions, and also stratification of the disease burden. We have research on diagnostics. We know we have transitioned from conventional diagnostic to newer rapid diagnostics. We have research on designing interventions, very common. We have research in drug trials. Tanzania, we are rich in research in drug trial, particularly lymphatic filariasis. We have also research in mobility management, like the mobility of lymphatic filariasis. We are talking about the wound microbiome, wound healing biomarkers. We have also social studies. We have research to define elimination endpoints. We have research to monitoring the impact of MDA for the preventive chemotherapy drugs. We have research on stigma, very important in diseases, and also we have research post-elimination. We are not there at the post-elimination research, but we are prioritizing to have research on those areas as well. I will not go through all those research areas. I've just selected a few. We will talk about the mapping, which is very important, surveillance, endpoints, and post-endpoint. In mapping, where we estimate burden of the disease, where we have these diagnostic tools to assist us in mapping. In surveillance, where we monitor the impact of the intervention. Endpoint, how we reach the endpoint, then we say we have eliminated a certain disease. And after elimination, we have to look for access to assess reemergence of the disease after interruption. This figure is just showing the same from the previous one. We have the phases in which we follow elimination of the disease. From phase 1, where we have treatment, where the prevalence is high, its baseline prevalence is high, and we put intervention like MDA, and we have a reduction in the prevalence to the level of interruption of transmission. And we do the phase 2, where we have post-treatment surveillance, which can take 3 to 5 years. And then we go to the elimination, where we do the post-elimination surveillance. This map, I will not say anything, but what I will say here is that we have seen a transition from prevalence, high burden, to the level we are right now. But what is important here is the research which lead to the mapping of the landscape, which we are now seeing this thing here. This is a study which was conducted, and they cited a reference by Malechela and the others. That's just show the role of research in the mapping. In the surveillance, yes, we do research on surveillance. Institutions, research institutions, and others are doing research, and the findings of this research are important for the programmatic adjustment. For example, finding of the research on surveillance show the progressive decline in the prevalence of the disease, for this case lymphatic filariasis. Research also show suboptimal MDA coverage, systematic and non-compliance, MDA fatigue, shift of vector from transmission by Anopheles to Culex conquifasciatus. And also research is coming with updated maps which can allow us now to target the interventions. The research which have been done in this area have informed the lymphatic filariasis control, and this updated risk map help to target intervention in areas of very good. Bring in mapping, which is very important in targeting the intervention, and surveillance will come also with the list of researches which has been conducted and give room for the program adjustments. For ONCO, the story is just the same. Research come and define variables which are important for transmission, for elimination, for defining elimination. Sorry. Slide are not moving. Mine are moving. Okay. So if you are not seeing, so I'm alone here. I'll just say for surveillance of trachoma, it's just the same, that we do surveillance to get the information which show us that the disease is declining, which show us that the program needs to do adjustment, and then the program does the adjustment to enhance elimination. And we have also the same for trachoma, which we have research which bring in a definition how we reach elimination threshold for elimination, and then we apply those in eliminating trachoma. What I can say, we still have some ongoing research on NTDs, which I will not mention them since we will not see them all, but we have a number like 7 researches which are ongoing for assisting in the elimination of NTDs. And lastly, which I can say, research is a requirement for elimination of NTDs. This room calling it to eliminate NTDs in a reasonable time frame, but this research has to be accessible, widely disseminated to reach decision makers and program manager. And those research has to be utilized for policy and practice. I thank you for your attention, and I'm sorry if the slides were not visible.
Thank you very much, Doctor. A round of applause for you. Research is needed for everything as we embark into universal coverage. And this morning we had a panel to discuss the intervention research. So if you were to move smoothly to the journey to the promised land, that universal coverage, we have to invest in the research. And I was very much happy to hear what NIMRI and other stakeholders have done in terms of research in the area of neglected tropical diseases. Now, let me take this opportunity to invite our final presenter, Mr. Douglas Ndeki. He's a seasoned health system manager, currently serving as the health secretary for the Tanzania Maternal and Child Health Investment Program, funded by the World Bank. He leads strategic planning, monitoring, and evaluation of health projects. Douglas has played a pivotal role in drafting key healthcare guidelines and developing, facilitating efficient resource mobilization tools. And he's the older master of science in health monitoring and evaluation. So please join me in welcoming Mr. Douglas. I don't know if it will work right now. Yeah. Yes. So Douglas, you have 10 minutes. Maybe we should allow Douglas to continue for the interest of time, because I'm afraid if we'll be waiting for this technical difficulties to be fixed, and it might consume a lot of our time. Please proceed.
Thank you very much. I'm honored to be here to address the big elephant in the room, financing for NTD intervention. Neglected tropical diseases affect people from poor communities. Okay, thank you. Affect people from poor community, mostly from low-income countries and middle-income countries. Unfortunately for these countries, most of NTD intervention are donor-funded, and they are subsequently funded very low by their government. The WHO roadmap of 2030 called for country ownership of NTD intervention. That call, among other things, mobilizing fund for NTD intervention. The WHO roadmap was also adapted by a regional framework, that is Continental Framework for NTD Control, which called the member states to advocate 2020. Tanzania is guided by a number of guidelines. For the purpose of time and for the interest of this session, I will highlight only 3 guidelines. One of them being Health Sector Strategic Plan 5, which have strategized preventive chemotherapy to 5 diseases as key strategy for eliminating NTD intervention. The other important guideline is NTD Master Plan of 2021-2026. This guideline has a number of priorities, but I will highlight only priority number 1, which needs it argue NTD program to strengthen government ownership, advocacy, coordination, and partnership of NTD interventions. And the last one, but very important one, sustainability of NTD, sustainability plan for NTD intervention. It has mainly 4 objectives, but the last objective is to increase domestic financing for NTD intervention up to 60% by 2026. After reviewing the global overview and Tanzania perspective direction on NTD financing, what is the role of the government in financing NTD? The first one, the government have a role to ensure NTD intervention. The third important task of the government is to develop, again, guiding partners in specific context area where they can invest on NTDs. So where are we in terms of financing? But, excuse me. As a side of partners, the partners have a role of working with government to identify gaps in financing for NTDs. They have a role also to build capacity in areas of planning and budgeting. They have also roles in financing and support NTD implementation at the community level and facility level. Development partners also have a role of giving countries technical assistance and innovating for NTD interventions. So where are we in terms of budgeting? NTD has been funded with a round of 9 billion budget average for the past 3 financial years. And the peak was at financial year 2020-2021 when the government, the budget reached 12 billions. This was caused by, among other factors, the capacity building we conducted to councils, which emulated the need for NTD planning at the council level, and we gave planners at council level interventions which they can plan, and we taught them diversification of sources of funds which they can be tapped in for NTD intervention. Eventually, this was achieved. Okay, thank you. In financial year 2023, we see a dropout of funding. This was caused by dropping out of some funders due as a COVID response in 2022-2023. In terms of budget sharing, for the past 3 years, for the first financial year 2020-2021, only 1% of NTD budget and expenditure was budgeted domestically. But after these interventions I've mentioned, we have seen promising development in terms of budgeting and expenditure of NTD interventions, as you can see. So where are these funds allocated? These funds are allocated to various interventions. The key one, as I've mentioned in the health sector strategic plan, is preventive chemotherapy, which have been allocated in most of funds because it is a national strategy for NTD control. Other interventions are, as you can see on the screen. In order to eliminate NTD, there is a need of cross-cutting intervention as also multi-sectoral collaboration. During analysis of budgets, we identified that there was various cross-cutting sectors which contributed to NTD intervention. One of them being nutrition sector. Nutrition sector have campaigned for nutrition and deworming. During those campaigns, they give albendazole to under 5 children. And that was very key to eliminating soil eliminations. Other interventions include vector control. We know we have been investing very hard in biolarvicidin for mosquitoes. And the other one, water and sanitation. We know we have been investing in water and sanitation. So the key challenges remain. NTD are still donor dependent in the country. Again, there is limited data to inform planning and budgeting at council and facility level. We understand also health sector have competing priority within limited resource setting. Again, there is low community awareness of NTD service. This in turn reduces demand of services in facility levels, and it is in turn reduce budgets at the primary level. There is also inadequate NTD-related support in structure planning and financial system. So where are we in terms of addressing these challenges? Okay. We have incorporated NTD situation analysis tables into plan rep in order to inform planning and decision making. We have redefined the NTD indicators in DHIS2 to fit current situation. We are continuing with stakeholders engagement, of course, to link with universal health insurance effort. As we have said, the key is to own this intervention. So domestic resource mobilization can be tapped easily in universal health insurance. And there is currently, we are developing financial strategies. The financial strategy is very important as it is going to landscape NTD resources. We are going to bring a gap of resource needed for NTDs, and we are going to identify sources needed for domestically funding NTD interventions, which will be very key for sustainability. Allow me to wind up by saying the following. Domestic resource mobilization will be attained if we improve skills of CHMT and health facility in charges in planning and budgeting. It will also be achieved if we build the evidence for national NTD level resources through results obtained at the council level. Thirdly, we will reach domestic resource mobilization by identifying and tapping resource financing using new resources rather than traditional and unpredictable sources of fund. And the other one is mapping of partners within NTD spaces, which therefore we can complement each other in implementation of NTD intervention. And the last but not least, but is very important, is ensuring that again we have gotten through intervention, we sustain them. This will reduce cost of intervention implementation in future. Thank you very much.
Thank you very much, Douglas, and a round of applause to Douglas once again. That was a very good presentation. So we had very good presentations from policies to implementation, the role of research in the NTD control and elimination, monitoring and evaluation, sustainability, and the issue to do with the financing. I must say that NTD is one of the a program which is quite very challenging when it comes to the financing. As majority of our development partners and implementing partners resorted to use the what we call direct-to-project funding. And very few of them, they support the Exchequer system. And we as a government, in the journey, of course, to achieve universal coverage, to be able to ascertain whatever amount of money which we are getting, and also to enhance accountability and transparency, we do encourage our esteemed partners to actually use what we call the directed facility financing, which is using the Exchequer system vis-a-vis the D2 funding system. So I would like to challenge our partners from this year and next year that please let us embark into the directed facility financing. So now the floor is open for Q&As, and I would like to pick up 5 questions as the first round, and then I will ask our esteemed presenter to respond, and we shall go to the second round. Can I see the hands up? So we have from Dr. Mtei, then we have Ogilo. Yes, and the other colleagues. So we start at the back, please. Be brief.
Thank you very much for the nice talk. My name is Danny Bwana. I hold a PhD in medical sciences, majoring in Kutoka and epilepsy. I've been doing research in the Olanga district in Maenge area. And recently there's a growing evidence that Kutoka can induce epilepsy. And there is a strong epidemiological evidence from different parts of sub-Saharan Africa, including Maenge, Tanzania, that if you can eliminate Kutoka, you'll be in a position to reduce the incidence of cases and also the morbidity that can be caused by Kutoka. So I was wondering if there's any plan from the Ministry of Health to include the morbidity management and disability prevention for the Kutoka, because we are sure that Kutoka epilepsy is one of the morbidity that can be caused by Kutoka. So I was wondering if I can receive the comment from Dr. Faraja, if there's any plan, the Ministry of Health, that have planned for the people of Olanga districts to prepare any kind of intervention that can focus to prevent the morbidity that can be caused by Kutoka. Thank you.
Thank you very much, and I must commend you and your team for a very good job which you are doing in Olanga. That has been transformative, so I'd really encourage you to, and other colleagues, to continue in that space. Can you take mic to Dr. Ogilo? Ogilo, can you raise up your hand? Yeah.
Main thing here is, and I would like to stress on it, integration, integration, integration. Once we integrate, we strengthen the curriculum. We make it a buzzword to the facilities. Budget will be cut by 50% in prevention. and not waiting for something to be done once in a year with so much donor funding for that. Integrate it, let it be partly planned by the councils themselves, or how they would like to do it, let them own it, and that will very much reduce the cost and will make financing possible. The way we are treating it now as neglected tropical diseases, having a week for something, people take the medicines and a lot of money going into it, at one time you might forget and things might come back to the way they were. So integration reduces the cost and making it part of the primary health care system, and let the district also come with their own innovations, and that might reduce the cost. Thank you.
Thank you very much. Mic to Dr. Tay and Dr. Nswila.
Thank you very much. I'm Dr. Mtei. My questions have partly been asked, but all the same continue. My question is, most of the work you have done is community-based. How have you engaged the respective communities? That is, how have you done your stakeholders' engagement with the communities?
Thank you. Dr. Anna, please.
Asante. Mine is that neglected tropical diseases ni ya miaka mingi sana. Kwa muda wote tukiiona ni donor dependent. Iko pure hata kwenye presentation Ministry of Health inavyoiona, lakini ninasema hamwezi kuwa successful kwenye primary health care unless, yes, you have presented that the planned CCHP is just a lip service. Tunaongea tu milioni sijui how many money president amesema ata inject. That one is just talking like that. Kinachohitajika chochote mnachopata integrate kwenye district, kakaeni wa own district, ndio hao wafanye hapa presentations za research za nani ni zenu. Data hamna kule, they will never be there, because if it is a program where project someone is being funded kwenye project yake, you are chasing the data kwa kuhakikisha kuwa your project unajibu kwa donor kupa, lakini halmashauri does not own. Facility haichukui. Siku hizi tuna watu kwenye level ya planning process ya health facility ambayo ni kwenye level ya health center mpaka kwenye zahanati. Let us capacitate them. Go with your money. Put it into their plan. I have been working with that NTD for a long time. Haijaweza kuministream. Na itaendelea hivyo hivyo. Pamoja na kuwa tunasema we are achieving elimination, it will be elimination ya jina. HSSP 5 ni jina, ni intervention zipo. Are they real? Ni kweli? Today we are talking, we are going to use community health workers. Kila program ya ministry, community health workers. I just wonder myself, how intelligent na capacity ya community health workers kubeba mzigo wa wizara au TAMISEMI au halmashauri, mizigo yote kwa wale community health workers. We have also to look into our research. Are they going to be capable? Tutafanya hivyo miaka 2-3 na kuendelea. Later on tutajikuta hatuendelei.
Yeah.
Put into practice, work on it, do it. Is it really possible? Will they manage? We are shifting something from ourselves kuhamishia mzigo kwa community health workers ambao tunajua hawawezi. Lakini tuangalie what support. We are shifting completely to talk about health facilities workers. Yani wametoka. Na community health workers watakuwa nani? Supervised na nani? Watakuwa oni na nani? Na wizara kama program itakuja kama vertical. Tuiangalie vizuri. It is a research and we need to go further. Finally, can we work with the One Health strategy? Because your presentation to the end, katika next step, as you talked about other interventions like nutrition na nyingine zote ambazo zina impact kwenye NTD, you should put there, then work with them again. See it, how much are they allocating so that indirect will work on the NTDs. Asante sana.
Thank you very much, Dr. That was a very good contribution. So those two must be the Mike Pale. Dr. Subi. So the time is not on our side. Can we have Dr. Subi's question or comment?
Thank you, Dr. Nturi and the presenters. It is good, the progress that has been made on NTD. Mine is quite on the snake bite. In 2019, WHO came up with a strategy on the prevention and control of snake bite. So I want to know what is the situation now in Tanzania, how the burden is, and what is our strategy. Thank you.
Thank you very much. So can we have, okay. That should be the last, and then I'll ask the panelists to respond.
Asante Dr. Nturi. Actually, alikuwa amenikinga, nimenyosha muda mrefu mpaka ikabidi hapa. I have two questions or three. The first one, kwanza nakushukuru for the very nice presentations to all of you. Was actually quite good. Now it's really awakening. Thanks for the comment, especially Dr. Mama Pale. As a country, we need to make decisions. Now, my question goes to the presentation that there is a lot of progress on eliminations. But any simple questions? What are the status of the surveillance to the places where we are stopping mass drug administrations? On that topic, how is the case management improving to those districts that we are stopping mass drug administrations? So that question, when we are eliminating and going away, stopping PC, MDA, we should be improving surveillance, we should also be improving case management. Now let me see how is the status among the clinicians to improve that angle. The second one goes to the MMDP. There is a low-hanging fruit on LF, hygienic management training. This does not need a lot of fund. Now, how many counselors have been trained on training patients on hygienic management of lymphoedema? Because it doesn't need surgery. And then on Ambakise, that there are some counselors that we have trained on surgery, on the trachoma and morbidity management. How many counselors have already reported that they have already actually improved on case management, on management of these complications on trachomas to date? And lastly, on the research, how are these research coordinated to support and inform the programs to improve interventions? Because I know almost all universities are doing this research. We commend you on that. But then without any coordinations to inform the interventions, actually we'll be working in silos. So these are my 4 questions to you. Thank you so much.
Thank you. Because as I said earlier on, the time is not on our side. So I would invite Clara to respond to some of the questions, and then colleagues from NIMRI. Clara, go ahead. The mic, you can use mine. Is it working?
Hello? Yeah, it is. So thank you very much. I'm just going to go direct to these questions. The first one was from the epilepsy-related onchocerciasis. Actually, as the program, we are aware of this morbidity, and last year when we had the the onchocerciasis elimination expert committee, this epilepsy related to onchocerciasis was one of the discussion, but the experts advised that now on the area of prevention. So as a program from 2022, we are ensuring there is availability of ivermectin in health facilities where there is cases of epilepsy.
Yeah.
And also there is a question which was talking about stakeholders engagement. Actually, stakeholder engagement with community members. Actually, NTD is one of the, I could say, one of the programs which engage community at large. If you remember our implementation structure, at the end, most of the activities, especially in MDS, are implemented by the community. So we usually involve them in planning. And for now, we are also implementing micro-planning in those areas where we start planning from the community level. So there is really high engagement of the community during the implementation because they are the one who does the work most of the time. And talking about donor dependent, yes, as the program, we know this is a problem, this is the challenge. And what have we done as a program? First of all, we developed the sustainability plan, which we have some copies there. And this sustainability plan is going to be an answer to the challenge we are facing of the sustainability post-donors. So if as a country we implement this sustainability plan, we're really going to achieve the last mile. And also we are working, as Ndaki said, we are working on developing the domestic health financing strategy, which is on the second stage. So we're also looking at how we can have finances from the, within the domestic fund. But also some of the donors in some of the implementation, they usually do direct to health facilities. And this is start from the region and district level as well. So the district, and so the question of integrating this activity in the CCHP, partly it is working because we have, from the district level, they receive fund directly to health facilities.
Thank you, Clara. Now I move on to Yahaya.
Sorry, there was a question on snake biting.
Time is not on our side, so I move on to Yahaya. I have only 2 minutes.
Thank you. My question was about how to enhance NTD elimination, control and elimination. What I can say is that's the role of NIMRI. NIMRI is doing the coordination of all research conducted in the country and make a room for dialogue with research which has impact can be adopted of NIMRI. Thank you.
Thank you. Next.
Yeah, yes, because collecting data, getting magnitude so that if we can now include in the program as one of the area of intervention programmatically. With status of MDA stoppage, is that currently, you know, diagnostics is a problem in eliminating diseases, control of the diseases. So currently we are conducting studies in various NTDs on the threshold prevalence, that is the target prevalence for stoppage, whether it is too rigid to attain or otherwise, but to stop MDA safely. So studies are ongoing on the current target. On
thank you very much, Douglas.
Thank you very much. Mine have been partly answered by the program manager, but if integration is key to sustainability. The NTD program have been doing a lot of integration programs. One of them was shifting of data, NTD data to DHIS2, where we integrated all vertical data to DHIS2. This allows us to plan with informed.
I'm afraid time is not on our side.
Okay.
So we'll stop there. But I might take this opportunity to thank you, every one of you, for having presented very well. And I would also thank you very much, the audience, for the contributions, the comments, the questions. And I must say that all the comments which you have given to us are well taken, and I'm sure the program managers here should be on those to making sure that she prepare the action plan so that whatever we have discussed here then can be implemented. Otherwise, join me to congratulate the team for a very good presentation.
30, we shall go into another parallel session. Just for quick reminders, in here will be led by ELCT, looking onto contribution of the faith community engagement. Sawa, they will take a joint picture. The lady should be in the middle. Number tusimame mbele ya meza. ELCT, contribution of faith community engagements. Kawawa will be looking onto financing maternal care. Zanzibar, the roles of social welfare. Rubondo, leadership and governance. Secretariat, community engagement and service delivery. This happens immediately after tea break, which is at exactly 11:30. Niwatakie wote mapumziko mema. We can carry up the discussion with the discussants as we go for tea. Thank you.